Hi, everyone. This is Robin Riddle with Stanford's Parkinson's Community Outreach Program, and we're so glad to have today Dr. Leila Montaser Kouhsari. She's a movement disorder specialist at Stanford, and she's going to be talking about how you can get the best treatment for your type of Parkinson's disease, or for your Parkinson's disease, rather. As we know, everybody has a different set of symptoms, and she's going to discuss how to treat the motor symptoms so you can optimize your quality of life. All right, take it away.
All right, thank you, Robin. And hello, everyone. Great to have you here. So as Robin mentioned, we're going to talk about treatments of motor symptoms in Parkinson's disease. So as you all know, PD is the second most common neurodegenerative disease after Alzheimer's disease. Approximately 60,000 Americans are diagnosed with PD each year, and more than 10 million worldwide are living with PD. Pathology-wise, really, Parkinson's disease happens after the protein that is known to be alpha-synuclein that starts getting stored in the neurons, and then basically generating Lewy bodies that, here you can see it with different staining. This is the Lewy body in substantia nigra, where the neurons generate dopamine. This is in hippocampus, and then also in a cortical region of the brain. Here again, you can see the substantia nigra, the area that is generating dopamine. This is like in healthy individual that the neurons that are generating dopamine are there. They're usually having a darker color. That's why the area is known as like substantia nigra, an area that is like dark and black. And this is in a patient that had Parkinson's disease, and you see that that darkness has gone, meaning that the neurons that they were here and were generating dopamine, unfortunately died. And that's when patients usually start after 50% of these neurons are dead. That's when patients start noticing the motor symptoms of Parkinson's disease. But what are the motor symptoms? I think most of you are familiar, but the classical clinical feature is bradykinesia, which is like a slowness of fine movements, rest tremor that comes out when patients put their hands or legs at the rest position, or it can come out when people are, walking, because usually our arms are at rest during the walk, even though we are like swinging them, they're not really maintaining a posture. And then, cognitive rigidity, that, usually when we do the examination, we kind of feel this friction when we are trying to move the wrist, elbow, or the legs at the ankle or knee position. And then patients have gait impairment, just shuffling of the gait, smaller steps, slower walking, decreased arm swing. That initially could be at one side, and then later when the disease progresses could be seen on both sides, and also postural instability that can cause falls. So this paper came out in 2018 by Fox et al. That, they put together all the treatments that were available for treating motor symptoms of Parkinson's disease, and, talked about their efficacy, and, how are they treating these symptoms in conjunction with other medication or, just by themselves. So I'm going to use this paper as the main reference. But again, I'm adding all the new treatments that are available at the market that was not available at 2018. So unfortunately, we don't have any effective neuroprotective agent. We don't have any medication to take not to get Parkinson, or, a medication that you can take and stop the progression of a disease or cure it in a sense. So what we have is just, what we can give to patients to bring them the closest, possible to their baseline. And, one of the most effective treatments that we have is Sinemet or carbidopa-levodopa that is, really giving dopamine, substituting the dopamine that patients are lacking. So, there is this myth going on about, should I take the medication? Should I wait and, suffer with the symptoms? Because if I take the medication, then, my symptoms progresses faster, or I'm going to have side effects. I'm going to have dyskinesia, which is like, involuntary abnormal movements. So a lot of patients, shy away. They have fear of taking the medication, and that causes them, to go years without really feeling comfortable. So this paper came out in 2019. It was a clinical trial called like LEAP study, and really wanted just to address this issue. So it was a multi-center double-blind study in early PD. They divided patients into early treatment group or delayed treatment group. In the early treatment, they started everyone with, taking the medicine, 1 tablet 3 times a day. In the delayed group, they started patients 40 weeks after, initialization of the trial. So these patients were, just went and did whatever they wanted to do, had the, and they were not on any medication. And basically then they reviewed the results at the end of like 80 weeks. And what they noticed was that, first of all, some patients in the delayed group couldn't really tolerate not being on medication because their symptoms, was not really easy to tolerate. So they moved them to the other group. But then the ones that they, stayed in that delayed group, when they compared them with the group that they were getting treatment, they noticed that there was like no significant motoric difference between the 2 groups. And then their secondary outcome was just like to see if there is any difference in motor fluctuations, dyskinesias, even like, in non-motor symptoms, cognitive scales, mood scales, and there was like really no difference. They noticed that, the week 4 to 40, there was definitely symptomatic benefit for the group that were on medication compared to the group that they weren't. But I also know they also noticed that patients that got started early on the medicine, there was no disease modifying effect of medicine, meaning that it was not that their disease didn't progress. So basically, if we want to have a conclusion, that basically shows that, getting started on medication is not going to add side effects, but also it's not going to treat the disease. It's just going to symptomatically, make the motor symptoms better. So, again, it's a question, kind of like a decision for patients. They want to start or not, but if they start, they're not going to put themselves in any danger. Again, there is another myth about if you start the medication early, you're going to have more motor complications. And there was this study again that they looked at patients that were diagnosed with PD in sub-Saharan African country, Ghana, compared to patients in Europe. So patient in Ghana had PD, but they didn't have access to medication for like a long period of time. So they started the medication much later in their disease compared to the other group that, they had access to the medication and they could actually take the medicine. And they noticed that when patients started the Sinemet later, the moment that they started the medication, they noticed some dyskinesias compared to, patients that started medication early and in later stage, they had dyskinesia. So this basically shows that even if you don't take the medicine for years, the moment you start the medication, if your disease has progressed, you're going to have some dyskinesia. So really motor fluctuation and dyskinesias are associated with the duration of them, not associated with the duration of levodopa therapy, but rather with longer disease duration. And if you need to be on a higher dose of the dopaminergic medication. So it's just really the combination of the dopaminergic medication and the disease progression. It doesn't really solely depend on the medication and timing of like starting the medication by itself. So available preparation of carbidopa-levodopa, the immediate release form. We have the orally dissolving Parcopa that, if patients have a sudden off, sometimes we tell them like chew the regular Cinemet, but with Parcopa, it can just like, you put it in your mouth and orally gets dissolved. Then we have the controlled release or long-acting form of Cinemet that, it actually releases dopamine in a sort of like a constant way over hours. And, it can help in patients that they have side effects with Cinemet. Either they have dyskinesias or, if they have low blood pressure, or if they have off symptoms. So this can actually help to sort of release dopamine in a more controlled fashion that can help with these issues. Then there is a form that has also the entacapone, which we're going to talk about a little later. It's an enzyme. There's an enzyme that metabolizes dopamine, and entacapone basically inhibits that enzyme so that dopamine can stay in the system for a longer period of time. And then we have Rytary, which is a capsule that has sprinkles of short-acting and long-acting Cinemet. And again, for patients that they have a lot of fluctuations, and dyskinesia could be a better option than the traditional Cinemet. We also have the levodopa intestinal gel that's known as Duopa. So it's basically continuously releasing dopamine during the day. So they need to be a J2 put in at the beginning of a small intestine, and the dopamine is going to be released in a more continuous way. It doesn't really affect the gastrointestinal transit. And it seems that, there are some complications, but like really limited to, abdominal pain in some people. It could be that device insertion gets loose and has to be tweaked. And some patients can have infection after the surgery, but very mild. I'm actually surprised that we have it at 47% here, but usually the complications are just like very mild. Okay. So also, we have a newer product that is under development. It's known as Neuroderm. This is continuous subcutaneous infusion of liquid Cinemet. And, this is basically learned from all the, diabetic patients that they're having like insulin pump. So it's kind of like the same idea. And the purpose is that, we basically try to keep the level of levodopa stable in the bloodstream, to try to reduce the off time. And also if someone has like an on or off time dyskinesia, try to reduce that. So it's available in the low dose or high dose, that you need like 1 infusion site for the low dose and then 2 infusion sites for the high dose. It seems that, the complication is usually having some inflammatory response to the site of infusion. It could be like skin rash or some inflammatory, like, nodules that can happen in some individuals and might not happen in others. We also have the sort of levodopa that can be inhaled. Again, this has been picked up from like inhalers that are used like in asthma and other respiratory diseases. This is again really good for patients that have sudden offs. And it has been FDA approved in 2018. Again, they did a trial that, used the placebo versus the actual levodopa powder. And they noticed that, in the low dose, it has like a 60 milligram, 84 milligram after 30 minutes. And then for the high dose one, after 60 minutes, patient's symptoms got better. And it seems that the side effects was just some throat irritation, some coughing, and sputum discoloration, and upper respiratory infection. But again, they were not that common, and there was like no change in pulmonary function test, so not really affecting the lungs at all. And this basically shows that they looked at it over time, and they noticed that at the end of the week 1, they actually had at 30 minutes there was like a significant difference between the placebo. Even at 20 minutes, the effect is still significant. And at the end of the 4 weeks, again, they had response at 20 minutes and 30 minutes. And you see even after 10 minutes, there is a good difference, small, between the placebo and medication. And all right. So the other medication that can be used for treating motor symptoms besides Sinemet are dopamine agonists. From this group, you might know pramipexole or Referral or ticotine. These have like brand names that are either Nupro patch that you might have heard, or Requip. And again, there were, clinical trials coming out to see if, it's really any difference between starting someone on this dopamine agonist that really works on the receptor of dopamine rather than like, giving dopamine. So they kind of like stimulate the receptor and the brain thinks that, oh, wow, like dopamine is available. And interestingly, when they compared the levodopa with Referral, this basically graph shows you the proportion of patients that remain free of dyskinesia. It kind of showed that, patients that were on the Referral, they had lost dyskinesia over the years. But again, they also noticed that levodopa was, better in controlling the off symptoms and fluctuations. So the conclusion was that even though patients might have less dyskinesia on dopamine agonists, the efficacy of like medication working for their symptoms is also going to be less. So the reason levodopa might cause more dyskinesia is just like because it's like a more potent medication. And also, the reason that a lot of doctors in academic centers stay away from prescribing dopamine agonists is just because they can cause impulse control issues that, include pathological gambling, compulsive eating, compulsive shopping, hypersexuality. And you see that this basically shows that a lot of patients over the years can actually have these symptoms, like, after 5 years, 50% can have the symptom. Even, people that initially didn't have any of these symptoms. So we always have to monitor if we put the patient on this medication and have a conversation with them just to be sure that that's not the side effect that they're having. And again, what are the side effects of dopamine agonists? They can also cause excessive daytime sleepiness. So when we start the patients, we usually tell them, in the first couple of days, be careful. We have had patients that, they were driving, they needed to kind of stop at the, side of the road and try to have a nap. For patients that they already have hallucinations, it can make it worse. It can cause orthostatic hypotension. So when patients stand up, they feel lightheaded. And it can cause edema, swelling in the legs, can be addictive, and at times it's hard to taper patients off. So if we want to do that, we definitely can. And some patients it's just really hard. So we have to let them be on it, because when they take it off, they don't really feel great. But it seems that 1/3 of patients can have really withdrawal symptoms. That could be panic attacks, agitation, fatigue, mood can go down, sleep problems, restlessness, and even, suicidality. So I think it's important to keep that in mind. The other group of medication that can be used as an adjunct, or, it can be used by themselves, are psilocybin and rasagiline. This is a medication we use early on, in early PD. If someone doesn't want to start Sinemet, can be on these medications, and that basically what they do is that they inhibit the monoamine oxidase B, an enzyme that metabolizes dopamine, so increases half-life of dopamine that the brain generates. Or, if you are giving it in conjunction with Sinemet, it also elongate the half-life of Sinemet itself. So psilocybin can be metabolized to levamphetamine. That's why, patients should not take it late during the day. But also, it could be good because if someone has a lot of sleepiness and fatigue during the day, can work as a stimulant. Rasagiline doesn't have that. There's a newer product, sulfonamide, that can be used as an adjunct with Sinemet. And this one, besides, controlling the enzyme, can also affect on voltage-dependent sodium and calcium channels in the brain and reduce neural glutamate release. So it actually works on different mechanisms, but overall, it hasn't had like more effect than the other older medication that we had. Amantadine, again, as a single therapy, might not be efficacious. I mean, this was a medicine that when we didn't have Sinemet, we were treating PD patients with it, but now, mostly we use it as an adjunct with Sinemet. And usually, we use it when patients have either a lot of rigidity, stiffness, or they have freezing of the gait, or they have dyskinesia, because it really helps with better gait and also controlling these involuntary abnormal movements. We have to be careful in prescribing it in elderly, especially if they have dementia, because it can make the cognition and also hallucinations worse. Again, with patients that have kidney disease, you have to calculate what the creatinine clearance is and adjust the dose based on that. It can cause dry mouth. Could be good for people that have a lot of drooling, but it can make the constipation worse. Again, it can cause orthostatic hypotension, leg swelling, nausea, and livido vesicularis, which is like, this particular branching of vessels that doesn't have maybe a nice appearance. It's mostly like appearance that can bother patients, but definitely if it's a side effect that patients don't like, we will stop the medication and that should go away. So we also have newer versions of Amantadine. We have Gocovri, which is like the extended release form. Patients can take that once at night. Usually it's costly. And then there is another version that's called Osmolex, which is a combination of short-acting and long-acting amantadine together. And it is less expensive than Gocovri and can be used for dyskinesia. Then, usually we have anticholinergic medications that a lot of times we use them for muscle tightness. They can also help with tremors. They're good for younger patients because of, side effects that they have. They may not be the best medicine for older individuals. If patients have a lot of motor fluctuations, which is basically on and off medication, then we prescribe dopamine agonists, which, we talked about it before. We can actually have levodopa extended release. We can use levodopa intestinal gel, and also we can use COMT inhibitors. Is there any question? I saw something in chat, but I didn't read it.
No, there nothing so far. I myself had a couple questions, but about Nuoderm and Duopa, but we'll wait till the end. But if anybody has questions, just put them in the Q&A box or the chat, and we'll get to them.
Okay, great. So so about the COMT inhibitors, these medications, their role is just, to prolong the effect of levodopa, again, by inhibiting the enzyme that affects on dopamine. In this group, we have entacapone, which usually patients need to take this medicine with each dose of Sinemet for it to work. There was like tolcapone that was kind of inhibiting COMT enzyme, both in the brain and the periphery. And patients were taking that 3 times a day. But because it affected the liver, and there were some deaths related to that, these days, no one really uses it. There's a newer product. It's known as FDA, approved by FDA recently. It's called Ongentys, opicapone. This is also a peripheral COMT inhibitor that can be used once daily. I mean, it's easier than the other ones. And it increases the daily on time. And basically, this shows that, patients can take it at the end of the day. If there are issues with liver, and then if, there is a history of particular cancers, just that they need to stay away from this medication. And lastly, there is also a newer medication known as Norions. This is like adenosine A2 antagonist, sort of like, the closest to caffeine. It could be likely efficacious. And again, it's a newer medication that can be used for motor fluctuations. If patients have like a lot of on and off symptoms, it can be helpful. Again, sometimes, we try to use a medication known as zonisamide that can be helpful. Usually we use zonisamide to control seizures, but, can be used if patients have a lot of dyskinesia and motor fluctuations. And lastly, we have Apomorphine. Again, this is a medicine that, we don't use it as much because of the side effects. It's not really an opioid, it's just that the name carries morphine in it. It's a non-selective dopamine agonist, cannot be used orally. It has to be injected with a pen. So it's sort of like a subcutaneous injection. And, it is really dopamine. So again, it's going to affect very quickly. So if patients have like acute off symptoms, definitely this is something to use because it can actually help with treating the off symptoms very fast, even faster than the Inbridge or the inhaler that I talked about. And the only issue with this medication is that, it causes nausea. And there is some pre-medication with antiemetic medications needs to be done. So patients need to take a medicine to control nausea before using this. And it seems that after, some time of using this medication, body adapts to it. So nausea goes down, but it could be an issue for some individuals and also can cause low blood pressure. Recently, there is a newer version of Apomorphine, which is like a sublingual film that came out. It's known as Kenobi, and basically, again, patients can use that if they have like a sudden off period. Again, they have to be careful about nausea and they have to be careful with orthostatic hypotension. The companies usually send a nurse over for the first couple of times that patients are using these medications just to monitor the symptoms and see that, what their blood pressure is, if someone is interested in using this type of medicine. And last but not least, deep brain stimulation. So, if patients are having a lot of fluctuations on and off, they have a lot of dyskinesia, then, it's a time to visit, procedures such as like deep brain stimulation. And I think we talked about this. Dyskinesias, again, if someone really having bad dyskinesias, they should think about more like either DBS or the intestinal infusion, DOPA. Amantadine can be used. And unilateral pallidotomy is not getting done as much these days. But again, we do have the focus ultrasound that can help dyskinesia. At the same time, it can help Parkinson's symptoms, tremor, and bradykinesia as well. And clozapine is like a medicine that we're used a lot for controlling psychosis. And they noticed that, it can actually help dyskinesias as well. So it needs a lot of blood monitoring because it can decrease the white blood cells and it increases cardiac risks. So, but if someone has like a really bad dyskinesia and they don't want to really get DBS, maybe that's like a last resort to use. Okay. All right, so I think we are done with the talk. And we can answer the questions, and then after that, I will get to the brief description of the study that we are doing.
And what are these questions?
Oh no, this is just basically gets back to the study that
okay.
questions in our study. Yeah.
Okay.
So actually, back.
Yes. So I had a few questions.
Sure.
It seems to me that there's a long list of available treatments, and many of them are efficacious. How do most movement disorder specialists decide how to treat Parkinson's, since there's a long list of possibilities? For example, do you usually say, okay, well, this person is between 40 and 65, so I'm probably going to put him or her on rasagiline first, and then in a few years I might introduce carbidopa, levodopa. Do you have a sort of a standard approach like that, and do other movement disorder specialists have different standard approaches?
Yeah, there is nothing really set in stone. I mean, recently, AAN mentioned that even for the previously there was this class of thoughts that, we can initially treat with MAO-B inhibitor like rasagilene or solajuline and don't start patients on Sinemet. But now they release that standard of care for everyone, young, old, is Sinemet. So try to start everyone on Sinemet. So that has been announced. So that's why I think most movement disorder specialists start the treatment these days just by giving patients Sinemet, and that's what has been recommended. Again, if someone really doesn't want to take that and they say that I want to take something that elongates the effect of dopamine that my own brain is generating, you can always put them on the solajuline or rasagiline for like a little bit. And even some patients might say, I want to try dopamine agonist. I want to do that Sinemet. And we always like talk about pros and cons, but you can do that too. I think after that there is not really particular guideline to look at. I think some doctors have it's always like a discussion with the patient as well, what they like to do. Some patients want their dose of Sinemet to be adjusted, either increasing the dose or increasing frequency, and not add another medication. Some patients want to keep the dose low, but they are more open in adding adjuncts when they have fluctuations, they have wearing off, or they have this. So I think it's just a sort of like take it as we go. I think definitely trying to get advantage of changing the short acting to long acting would be good. I sometimes use even a combination of short acting and long acting. So doing those kind of stuff, that not increasing the dose, would be helpful. But I think at some point you need to use some adjunct, and I think people have different preferences on what they want to use.
Okay, that's very helpful. What about, so you've said that we've now eliminated some myths, for example, that if you start dopamine or Sinemet early, that you're more inclined to have dyskinesias sooner, what have you. It seems that our understanding of Parkinson's treatment evolves every 5 or 10 years. There's a new pronouncement about, well, this is the preferred model. Do you also see it as a changing medication suggestions over the years?
Yeah, I think Sinemet has been around for like a long time, but I think the fact that taking it early is not going to cause any issues. This is pretty new. And I think that previously even some physicians believed that that's the case, and they kind of wanted patients to start later, or if they were saying that they want to start later, they wouldn't offer this knowledge. But I think that now at least we know more about what it does actually and what it doesn't. So I think that helps to guide patients to make a better decision for their own.
Right. Okay.
Treatment.
You mentioned Duopa, which is the levodopa gel that's administered through a pump. And is that really for what we might call advanced Parkinson's disease? And how do you define advanced? How do you know when someone's advanced?
Yeah, that's usually for patients that have a lot of fluctuations. So, when someone needs to take the dopaminergic medication every 2 hours, every 3 hours, and when they're reaching that, 2 hours time, let's say, they start having really bad off symptoms, they can't move, they're kind of like frozen. Or if they have like a lot of dyskinesias either before the next dose or after they take their medication. So, the medicine works for 2 hours, and then when they take finally the medication, then they have like dyskinesia, which is like, a lot of movements that is like out of their control for like an hour. So really, they have maybe an hour between each dose that they can do their normal life with. So that's really hard. So, and unfortunately, the medication sometimes like Rytary might help because it has like more elements of short acting and long acting, but sometimes it just doesn't. So at that point, I think they need something that makes the dopamine more stable. So they have to go either for the this sort of like intestinal gel pump, or they need to go for deep brain stimulation.
Okay. And how would the Nuoderm then fit into that menu? Do you also view Nuoderm as something for advanced Parkinson's or people who have
The same population are
Okay.
also eligible for that.
Mhm.
It's still in the clinical trial phase,
Yeah, right.
but I think when it becomes available, definitely can be used. I think they both have like pros and cons. I think for the Neuroderm, some people have reactions to the site of injection, which for Duopa you don't have that. But then again, for Duopa, you have something that is sort of going all the way into the GI system. With Neuroderm, it's sort of like subcutaneous. So I think it's just but again, it's like something that people have to, the pump is outside of body, so they have to carry it. They found like good ways to kind of help patients to carry it like, as easy as possible. But that's like an extra thing that the patient has to have it on their body when they're out and about.
Okay, all right. One thing you have not mentioned is exercise. What do you advise your folks with Parkinson's disease to exercise in addition to considering medication?
Yeah. Exercise is, we talked about the medical kind of like treatments. But exercise is like the best way of helping the body to, kind of go and fight with the disease. So, we have evidence that it can decrease the progression of the Parkinson symptoms. But also, I think overall, patients are going to feel much better when they're exercising. So the motor symptoms actually can get better. At times, patients might need a little bit of more. It differs in patients. Some patients feel like that when they exercise, they actually need less medication. It causes like some boost of dopamine. Some patients think that, they need a little bit of, more medication right before exercise, but then afterwards they feel really great. So, definitely they can do as much as exercise they can. And we recommend that to do it as like taking the medication. But then again, the regimen can be tweaked in a way that they can do their exercise the best way.
Okay, we have a few audience member questions. One is this person has a drug-induced Parkinsonism. So Parkinsonism that's induced by antipsychotics or neuroleptics. And she asks, are any of these treatments like carbidopa, levodopa, Sinemet, or any of these other treatments applicable for her type of Parkinsonism?
Yeah, I think the best treatment is just to stop the medicine that is causing the Parkinsonian symptoms. But in some patients, that's not possible because they need to be on that medication for psychiatric issues. And because, a lot of psychiatric medications can cause that. Then, we usually do some consulting with the physician that is giving the drugs that is causing the Parkinsonism. And, if they mention that it's okay to give the Sinemet, because usually antipsychotic medications that they bring the dopamine down are causing these diseases, and you need to bring the dopamine down to control psychiatric symptoms. And so giving dopamine can actually increase these psychiatric symptoms. So I think I have had patients that, their motoric symptoms was just really bad, that we needed to treat them with Sinemet for some chunk of time. But I usually do it's not a decision I make just by myself. I always bring in the other physician that is giving them the medication, and we kind of make a mutual decision.
Yeah, sounds very complicated. One person says, so far, only my left side is affected. I take 1.5 tablets every 4 hours during the day of Sinemet 25/100, none at night. I have some mild involuntary movements during the morning dose. Is this dose considered low, medium, or high?
Well, I mean, the involuntary movements is after taking the medication or before?
This is, I have some mild involuntary movements during the morning when he replies after.
Yeah, so,
Yeah.
I mean, it is possible that the morning dose, maybe it's a little high. So what can be done is that either they can try taking 1 tablet and see that they still have dyskinesia, or they can take long acting and see that, if that gives them enough dopamine to do what they need to do, at the same time having less dyskinesia.
Yeah, this brings up a question about sort of trial and error. How much leeway do you as a physician give the patient in terms of this sort of experimenting, dialing it back to 1 tablet and seeing if 1 tablet's enough, that sort of thing?
Yeah, I mean, I think there's a lot of room for doing that, because a lot of times if we don't do the exercise, we just really don't know. So because something that might work for one person might not work for the another person. So it's solely okay just to try it for like a week or 2 and see that if that's something that's going to help you or not.
Right. Okay. And last question is, I've been told that older patients cannot have deep brain stimulation surgery. Why is that? Or is that true?
Well, older patients, I mean, I think we do DBS till before 80. I think if usually because of comorbidities, we don't do it after age of 80. But I don't know if what age they have in mind.
Yeah, don't know. Okay, well, let's conclude there. Dr. Montaser Kouhsari, I so appreciate your giving a talk today about PD medications and giving us an update of some new things that are in the pipeline and some new things that have been FDA approved. Thank you so much for that.